by Dr. Soumitra Kumar about the entire, gamut which is going on. We have to have a sweet spot when we trade about bleeding risk and thrombotic risk. When we deal with acute coronary syndrome, there is always a chance of repeat recurrent myocardial infarction in coming 3-4 years, and it is not something very less. It's around 2 to 4% per year till 5 years of after the acute coronary syndrome, and then it fades away. So the maximum recurrence of myocardial infarction or repeat ACS happens in next 1 month, followed by 3 months, and then gradually from 1 to 4 years, it is 2 to 3% per year, and finally it comes down. So, and in that context, we have to plan for our antiplatelet regimen so that we secure the patient from having a recurrent myocardial infarction or a recurrent acute coronary syndrome. At the same time, we should not put the patient at risk for bleeding. So very, very rightly put by Dr. Kumar that first year, the thrombotic risk is a priority. So if your stent blocks or a patient after acute coronary syndrome who is just recovering, again there is ACS, the odds of survival is very less. And the bleeding risk is something which remains there for the patient. So the bleeding risk, which is with 2 drugs at 1 month, if we don't work on the reversible factors like liver disease, any alcoholism or any extra drug which the patient is taking, or these parameters, if or hypertension is not controlled, if the same risk factors are there, the bleeding risk at 1 month is same as 6 months. But the thrombotic risk really differs. It comes down. And that is whole idea about tailoring our therapy and so many trials. So I can't enumerate so many trials which have been happening. So we have path-breaking trials, which are some upcoming trials. I will give you a glimpse of these trials, and then we can discuss. So this is how antiplatelets have evolved from aspirin to ticlopidine to clopidogrel to prasugrel to ticagrelor. And then we also have a cangrelor with us now. In acute coronary syndrome, we also use cangrelor when the patient is in cardiogenic shock, when the oral drug, the bioavailability is not clear. So if a patient with hypotension, how much in blood circulation the drug is going on, your antiplatelet, be it a ticagrelor or a clopidogrel, it is really, really indefinite. So a cangrelor in that place can be really helpful in acute coronary syndrome. Or those patients who are vomiting, throwing out. So if throwing up patients 2-3 times of vomiting, so how much drug has gone in, absorbed, it's again indefinite, and the cangrelor is also there. So putting the entire list of drugs, antiplatelets, we can't leave cangrelor out. So we have a very strong contender, clopidogrel, ticagrelor, then cangrelor, and aspirin is obviously there, on which a lot of question mark has been raised in the last 1 decade. So, so in process of attaining a sweet spot, there have been some scoring system which has been developed. Something like precise DAPT or a DAPT score, and some other scores are also there. It says that the bleeding risk and thrombotic risk, and finally you plan. So if a patient has a score of DAPT more than 25, its more bleeding risk is anticipated, and you can have a shorter DAPT. Those with less than 25 in precise DAPT, which is easy to calculate, and standard or long standard, what is in guideline, can be done. So scoring may not be precise DAPT or DAPT. It can be well by our clinical judgment or physician's clinical judgment as well. Someone who is elderly, someone who is a low body weight, someone who is a CKD, someone who is a liver disorder, someone who has bled earlier, someone who has anemia, they definitely will have a higher risk of bleeding, and then what we call high bleeding risk patients, and definitely we can tailor it down to a shorter DAPT. So, use of risk scores as guidance for the duration of dual antiplatelet is a class 2B indication as such, but definitely it has to be taken into kind of enforcement by all physicians depending on the patient's characteristic. So let's look at the acute coronary syndrome, and if at all we go for a percutaneous coronary intervention, what should be the strategy? So in ACS, although the bare metal stents are not used nowadays, but still we'll talk. So if irrespective of stenting, it is a bare metal stent or a drug-eluting stent, the guideline is a 1-year DAPT, so which was pointed out by Dr. Soumitra Kumar. This is there in guideline, provided the patient is having a high bleeding risk, which entails you or which entitles you to bring down the DAPT to 6 months at least. So if there is a high bleeding risk to 6 months, and in a normal situation up to 12 months, the DAPT should be going on. And it depends which antiplatelet, second antiplatelet. Obviously, in acute coronary syndrome, ticagrelor is the second antiplatelet, which is preferred, followed by clopidogrel. BRS is also now more or less out of use, but Indian BRS is coming. So Indian BRS, we can, or BRS technology, when it comes from other manufacturers also, if we deploy a BRS, it has to be more than 12 months, because the healing and the endothelialization process takes a lot of time. Although it totally gets absorbed, but it's a thicker stent, and at times to get absorbed or endothelize is more than 12 months. So 1.5 to 2 years can be well enough, but more than 12 months or up to 12 months is recommended in the guidelines. And then finally, a stable coronary artery disease, obviously a 6 month is more or less normal. But our topic is acute coronary syndrome today, so I will be confine my talk to acute coronary syndrome only. If you go for a CABG in acute coronary syndrome, so what are you going to do? So again, if there is a standard situation, it's a 12-month DAPT is indicated. And if there is a bleeding risk, which I enumerated with risk factors, I will also tell you what are the high bleeding risk patients. And there are definite criteria that are there. And anyone can type in Google and get an idea about HBR patients. And then a 6 months abbreviated therapy is recommended in those patients. Medical treatment in acute coronary syndrome, again, it's a 12 months. And if the patient has a high bleeding risk, we can come down to 1 month. So this is very important. One should appreciate if patient is having a acute unstable angina or even a small MI, if kept in medical management, high bleeding risk patient, 1 month is enough, but 12 months is recommended. If patient has acceptable bleeding risk, it has to be one year. I am going to throw some light on some controversial issues rather than standards we dealt with. We discussed how much duration, how is the bleeding risk, how we define the patient's risk factor for thrombotic and bleeding. But there is a topic study design where if someone is on ticagrelor, if we switch to clopidogrel, then the clinical outcome in switched DAPT was better. So the incidence of adverse events, cardiovascular adverse events were lesser. So this was one trial which shows us against many trials which have shown a single ticagrelor can be better, but it is a dual therapy. So when you are contemplating for a dual therapy in post ACS in stable angina patients, so in a medical management patient, you can well appreciate a clopidogrel role also. Otherwise, in a PCI, in acute coronary syndrome, it is ticagrelor most of the time. So studies examining extended DAPT. So there was a time, especially in the earlier first decade of 21st century, where a lot of work was done on extended DAPT. And after 2010, there is a work on shorter DAPT. So there is a huge change in our think process. And it is not because of the basically the failure of the initial trials, but it is because of the evolution of the stents and the treatment. So majority of the patients of acute coronary syndrome, they receive stents, and these stents are newer generation, lesser strut thickness, chances of thrombosis is less, so a shorter DAPT is good enough. But I will go use some trials. And this was what I told you, 2010, up to 2010, a lot of trials were done. The Pegasus TM54, we all know, it showed us benefit in ticagrelor plus aspirin arm in those patients who had a previous MI, and there was a significant lesser thrombotic risk but the bleeding risk were really high. You see fatal bleeding where ICH more were in ticagrelor plus aspirin. So we can't get a conclusion from there, and the Pegasus real world utilization is really very less. I can appreciate, I can tell you. Now there is a polymer-free drug-coated coronary stents in patients at high bleeding risk. There are some trials on that, and I can appreciate here a single antiplatelet can be better in these patients because of thinner struts. And these are again some trials right from beginning on DAPT and antiplatelets. So new data in 2021. We talked about the perspective. We talked about the kind of hypothesis behind thrombotic bleeding. We talked about the recommendations. We talked about how the trends have changed from earlier 2000 to 2010 to 2020. But what is the new data in 2021, where we are heading towards? So we have got good trials with a single antiplatelet after 1 month to 3 months period in terms of twilight, in terms of heart trial, and we have many trials like topic, TICO trial and Onyx trial, Onyx 1 trial. I will take you through some of the landmarks trials. And one of the important new trials which we talk about in 2021 is Master DAPT trial, whose extended arm was published a few months back, but it is an ongoing trial since last 3 years. And it is the last trial, 4,500 patients, where an abbreviated regimen, single antiplatelet versus 2 drugs are evaluated. And what they found was, again, death, MI, stroke was not different, but definitely the BARC 235 bleeding were less in abbreviated DAPT. So you see the thrombotic risk remains same, but the bleeding risk comes down. So this is a very clear indication that although these are all trials are made on stents, which are thinner stents, and this is on Terimose Ultimaster, but these are giving us a trend. So forgive me if I am going more towards stenting, because ACS management is mostly, high risk ACS patients. When you go for stenting, then only this entire apprehension about long short-term DAPT comes into picture. If we manage a patient ACS, although we should give a 1 year DAPT, but if a bleeding risk patient, you can well close it in 1 month. So it is in guideline, we can do that. But problem happens when there is a stent, and that is why I am more on stenting in acute coronary syndrome and what are the results. So this is with Ultimaster trial, Master DAPT, a single antiplatelet at 1 month. If you stop, the results are almost same. Stop DAPT 2 ACS trial again shows a similar finding, 1 month DAPT versus 12 months, and there was not difference. Clinical outcome at 1 year, CV death, MI, large MI. So you see there are not much of difference, and the patient is basically, the bleeding becomes very less. You see here the hazard ratio 0.41, very less. The MI risk were definitely higher, but the numbers were very less, and death was 1.49 with a confidence interval of 0.83 to 2.67. So nowhere we are getting a very clear-cut mandate, but definitely there is no problem when we stop it at 1 month. Global leaders for one trial, which I referred to earlier also. This was a large trial after stopping of DAPT, it was with a single ticagrelor, and they again say that this is a negative trial, but I don't think this is a negative trial. There also, days after index procedure, there was not much of, the bleeding risk reduction was seen, and the thrombotic risk was marginally higher. Onyx 1 global study design again showed a Onyx result with against biofreedom DCS drug-coated stent. So there is no polymer here. The drug is directly coated on the stent, and which is considered to be very less thrombogenic, and Resolute Onyx performed similar when at 1 month the DAPT was stopped. So Onyx 1 trial SAPT analysis, aspirin versus P2Y12. Again, this was aspirin P2Y12 monotherapy had a better outcome. So this is a ARC Academic Research Consortium HBR trade-off model. So what I was talking about, the HBRs and all these gametes. So we must know what are the HBRs, and HBR is something like patient is having a smoker, anemic, renal dysfunction, age more than 65 years, oral anticoagulation, is a CPD, liver disease, cancer, plant surgery. So these are basically when you have got these factors. These patients have high chance of back bleeding, and these are high bleeding risk patients. But those patients with thrombotic risk are complex PCI, again a smoker and anemia, renal dysfunction, and high thrombotic patients in STEMI, obviously diabetic, prior MI, and bare metal stents. So these are predictors of MI and stent thrombosis again. And these are the trade-off model, when to stop it, and how the risk of thrombosis and bleeding matters. And we have more trials coming in line, acetyl salicylic elimination trial. So we are moving away from aspirin, that is no doubt. And these all ACS managed by stents. We have trials not only with clopidogrel, ticagrelor, we also have good trials with prasugrel. So, so a lot of trials coming on, you see, where antiplatelets, shorter DAPT has shown benefits. And with these words, I stop here. And it will be very interesting to have a word from our chairperson, which way we are going and how it is going to be unfolded. Thank you so much.
Thank you, Dilip. As usual, you have made a very